Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for clinicians in Aotearoa, New Zealand. Reducing Risk looks at key medical legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. This current series is focusing on demystifying the Medical Council's standards, and today we're looking at the statement on resource constraints, which is a very hot topic. And through the MPS advice line, we're getting calls every day about the medical legal risk of working in areas of resource limitation. Look, this is such a huge topic that we've actually decided that we're going to divide it into 3 separate podcasts. And we're going to start with our primary care colleagues and talking about the aspects of resource constraints in primary care. And then the next podcast will be on resource constraints in secondary care. And then our final podcast will be looking at the HDC and how they approach issues that have arisen in situations where services have been unduly stretched. So this podcast is covering the issues of resource limitation in primary care. My name is Dr. Lucy Gibbard and I'm one of the medical legal advisors at MPS. And today we're lucky to be joined by Sam Murton from the Royal New Zealand College of General Practitioners. Hello, Sam.
Hiya.
We also have Sean O'Sullivan, who's a partner at our panel law firm, Wootton Kearney. Hello, Sean.
Hi, Lucy.
And I'm also very grateful to be joined by my 2 colleagues from MPS, Dr. Sam King and Dr. Chow Yen Chen, who are both medical legal advisors at MPS.
Hey, Lucy.
Hi, Lucy.
Hi, guys. So look, before we start, I just thought it would be helpful for Sam to briefly tell us, because we're talking about primary care here, what the Royal College of GPs is doing for advocating for under-resourced general practice. And just if you wanted to tell us where things are at from your point of view, Sam.
Yeah, thanks, Lucy. I think the under-resourcing is a variety of different aspects, which is the fact that the workload's increasing, so we need resource to be able to manage that. The fact that we do have a workforce that's shortage, and so that's difficult. And I think complexity of care is another issue that we have to face and deal with as well. But all of it means that we need to work in a different way and make sure that we are keeping our business running in a way that means that we're safe, but also that our patients are safe as well. So it's a complex area, and there's lots of things that we need to work on. Yeah.
I think it's a good thing to, if we start maybe understanding the fact that the Medical Council do have a statement on safe practice in an environment of resource limitation. And I know that many of our members haven't had the opportunity to read many of the Medical Council statements, but I think it's actually a really good thing for all of us to do because resource constraint touches every area of the health sector.
Yeah, and it's good. It kind of lays out what our responsibilities are in when we are working in an area of resource constraint, because we often do get calls from doctors saying, you know, what am I supposed to do? What's the professional way of behaving when I can't do the job that I've been trained to do because there isn't the resource to do it? So I think it's really helpful to know how the Medical Council are going to actually judge us in those situations. And look, it also contains one of my all-time favourite statements, which is that you can't be held responsible for not providing what is not in your power to provide. So it's nice to know that they can't criticise us when we can't do what we can't do. The issue is, though, that you can be held responsible for making sure that your patient is supported, understands the reasons why some services are delayed or not available at all. And so it is part of our responsibility is actually understanding what the resource constraints are, how we can manage them, and making sure our patients understand that too.
And that's right, Lucy. I think when we'll go on to it, but I think one of the themes that comes through that statement is that you're an advocate for your patient and that advocacy. So it's not a simple matter of closing the door. It's advocating very well for the patient. That theme will come through as we, I think, keep talking.
I'd just like to acknowledge too that just the pain in primary care, I mean, obviously it's in secondary care as well, but the pain in our sector is quite significant with resource constraints. So I just want to acknowledge our colleagues out in primary care for the hard work and the difficulties that they're facing, and that, you know, just about everyone's doing a brilliant job in the face of what are difficult circumstances.
And I think, you know, most of us, or every one of us, wants to do our best for our patients, and when the resources aren't available that we can do that, is distressing for us as it is for our patients. So it is very difficult and emotive is the problem. Yeah.
Absolutely.
Yeah, we were just talking the other day that 15 minutes is not enough time to do very much at all.
No.
You might get a set of obs done, and then you've got to establish rapport, you've got to manage risk. It's not very long.
Yeah. But fortunately, we have lots of 15 minutes is available over a year. So, so it does make a difference. But you generally do know your patients, but it isn't enough time to do really complex work, and that's the problem. Yeah.
And the work is getting more complex, as
Yeah.
you said earlier. That is the problem. So look, I thought we'd start with an oldie but a goodie, and that's about inbox management. Look, there's so much out there about inbox management. It's a huge topic. And it really is at the heart of resource constraints in general practice, I think. I know that when I trained in general practice 25 years ago, my inbox was just a few bits of paper that came in on a clipboard at lunchtime, which the nurse got you to initial. And, and you'd talk to the nurse about, can you follow that up or get that patient to make an appointment? And that was your inbox done. Whereas nowadays, life is very different. And the model that we're working under hasn't really necessarily completely been able to keep up with the amount of work that the inbox is actually generating these days. And I know that as a part-time GP myself, I get 100, 150 between that, results or scans or letters every day. And that's even on the days when I'm not working. And I can't imagine what a full-time GP is getting some places, especially with the ones with larger lists or with complex patients. So I think we all have to acknowledge that the inbox is a big part of our resource constraints. And at MPS, one of the commonest questions to get around this is, can I be held responsible for results when it's in my inbox, but I didn't order it? And in fact, I may not even know of the context in which it was requested.
It is really a constant concern, and I know that, various presentations that we've gone and done around the country, it's really interesting to hear what our GP colleagues are saying. And I know it ranges from GPs who are very conscientious and look at every single test and take responsibility for every single test, to I've heard of the occasional GP would say to me, if I didn't order it, I'm not looking at it, I just file it without looking at it, which perhaps isn't the right thing to do.
With your MPS hat on, you would be very worried about.
Exactly.
Sam, I'm sure we've had a case on that where someone was criticised for that. I'm trying to remember it, but I'm sure the HTC, at least it was an adverse comment where, if it came into the inbox, they held the person responsible. Obviously, there were other people perhaps more responsible, but they didn't escape criticism in that situation.
That's right. GPs don't escape criticism. We have a secondary responsibility that is very hard to get away from. Yeah.
Yeah, so I think the answer is that if you see the test result, if it's in your inbox, even if you didn't order it, you may not be responsible for following it up, but you probably are responsible for making sure that somebody is following it up. I think that's the important thing there.
Yeah, and I think, there are cases. I mean, I've had a personal case where there's something that came into my inbox and it was several weeks later, and from when the test was done, and this person had a significant illness, and I thought, well, so-and-so did it, it would have been treated. And when I saw him a few weeks afterwards, I said, how did the treatment for your such and such go? And he goes, what thing that I had? And so it had been ordered in the hospital, and no one had followed it up at all. And it was such a significant thing for him in particular, and for the service that was looking after him in particular, that there was no doubt that it should have been seen. So that's really difficult if I was going to be held responsible for that, because it was something that was really totally in their court to be dealing with. And I think the thing that we have from a college perspective and the conversations that we've had is that our computer system is not a computer on a desk that just holds records of particular patients. Our computer system is now, over 20 years, morphed into this interconnected beast that has everything available in it, and also is the one place that portals can be get access to all the tests from. So therefore, it becomes the default setting for everything that a patient needs to know, and the patient record. And we've had, as a college, we had a conversation with several people from the Ministry of Health, from Te Whatu Ora, with MPS, the Health and Disability Commissioner, and Medical Council, just talking about the fact that there is a health record for a patient and it all lands in our lap. And how do we manage that? And the HDC said, well, actually, health record is held in all sorts of different places, which actually felt really reassuring to me, that we don't have to feel that we are the one port of the sole record, but also the fact that there are some really critical factors that do need to be passed on from one to the other, and their interconnectedness is so important so that we can pass stuff on. So there's a bit of work going on there, but it does feel like we are holding the lion's share of the patient record of their health history.
I think part of the difficulty is that, as we're aware, the hospital systems don't necessarily talk to each other, even within a hospital. And so it's far more difficult for them to hold an integrated system, whereas in primary care, of course, it is held on one system. Yeah.
And so holding an integrated system is a great idea, but should there be one person or one group of people as a team held responsible for all of that? And that's actually really difficult.
Yeah.
Yeah.
Yes, so I think it is difficult, but look, there is lots of work going on in that area, and we are hoping that the situation is going to at least be clarified, so that everyone knows where they stand. And actually the college has got this really great policy briefing document called Managing Patient Test Results, which again, I don't know, there's all this stuff out there on the internet that often we don't see, but it actually is really good. It talks about the expected standards, and it's got a few HDC cases on there where clinicians have been found at fault for not following up test results. And interestingly, it's often the HDC is critical about the systems, so it's all very well having a good computer system, but you actually also need procedures and policies and protocols so that your practice knows who's got responsibility and what's happening there. So look, I think we might just leave inbox there, because I think we could talk about it for an hour probably, but I think we'll just carry on and go on to our next subject now, and we'll keep an eye on the college communications, because when this podcast actually comes out, there may be a whole new area there, so we'll keep an eye on what the college says about that.
Yeah, well, there's certainly lots of work going on in that place. So,
So the next system I wanted to talk about was that whole issue of taking over the care of patients with issues that would normally be dealt with in secondary care. And as primary care and secondary care both come under significant resource constraints, it does appear like there are a lot of hospital systems where care that would traditionally have been given in the hospital is now being sent to GPs to take over, which can lead to several issues, not least of all the equity issue, because these hospital services are often free, and when that service gets transferred to the GPs, often there is no funding with it, so the patient now has to pay for a service that was previously free to them. But also there's the issue of, have the GPs got capacity to do it? Have they got the skills to do it? And I think that, the issues there can be significant, Sam. What are your thoughts on that?
Yeah, there are some really specialised, for example, medications where specialists would normally be monitoring patients. I'm thinking about, DMARDs or the biologics for the rheumatoid patients, or even clozapine in some areas of New Zealand where patients can come into significant adverse effects, and so they need careful monitoring. But GPs aren't necessarily set up for that or particularly knowledgeable about those medications, so it does make it really tricky.
And it does increase workload, when in a situation where you've got resource constraints already, it can be significant. I mean, we've had one recently about starting patients on antipsychotics on specialist advice when the patient hasn't been seen by the specialist. Also being asked to do minor procedures, or, it's a gatekeeping system almost for the hospital sometimes, that we need the GPs to do X, Y, and Z, DIVA questionnaires for ADHD assessments and things like that, which is actually putting a huge workload on primary care in trying to reduce the workload in secondary care. But it does feel like that's a tricky thing. So the question medical legally is, how do we stand there? Do we have to do it?
Well, I can answer that. No, you don't have to do it. In fact, there are situations that will arise where you shouldn't do it. But I don't think your responsibility ends there. What you need to do is, as I said at the start, advocate for your patient and discuss with them whatever alternatives are available, and perhaps try and facilitate those alternatives to the extent that you're able to. So I think you're absolutely right to say no in situations, and in fact you probably should in some situations.
Part of the difficulty is, though, that it takes time. A patient comes to you, they're asking for this, particular medication or treatment, and you say, well, it's not within my scope to be able to do this or my level of competence. And then it takes time for you to plug them back into the public system, for example, which means another referral, it means waiting time for the patient and all of those things. So it does still create work, even though you're not accepting to, whatever procedure it happens to be.
Yeah.
The unfortunate reality is every time you look after a patient, there can be more work generated.
Yeah.
So, for example, in private, if I've got a patient that developed issues during their anaesthetic and I've gone on to talk to them and refer them to cardiology, respiratory, or whatever other investigations they need to have, then that potentially generates a lot of work for their GP. Yeah, so, and again, got to be mindful of equity, but if they've got private insurance, then it's a conversation that I have with the patient to check if they're happy for me to do all the referrals, and then hopefully it reduces the workload on the GP.
Good on you, Chaya. Thank you very, very much for considering your GP colleague.
Just a question on that. Do you think that the fact that it does create so much more work is potentially a worry that GPs will take on the outside of scope or just go a little bit further because, and is that a real worry? Because I think that is a concern from a medico-legal perspective, because that does open up a lot more vulnerability, I suppose.
There's a lot of discussion around what the secondary care people have asked primary care to do. And some people will just do it, and other people say, no, we're going to push back. I think there's probably a wide spectrum there.
But I think that the main thing is that we're all worried about the poor patient sitting in the middle of it. Because often if secondary care is pushing back and saying, no, we want the GP to do this procedure or manage this medication, if the GP says, no, it's out of my scope, no, I haven't got capacity, well, then often the poor patient in the middle doesn't get the service at all, and so I think that's what pushes doctors to work outside their scope a bit more than the workload issue. It's actually the fact that we know our patients in general practice. You often feel really sorry for them being caught in the middle of all this, and it does encourage you to actually just want them to have that service, and therefore that may mean that you feel you have to do it.
And I think sometimes you do, you may have the skills, but then you're charging a patient for something that they wouldn't normally get for free in a hospital. So there's that sort of level of how much will I gift some of the service that I'm providing.
Yeah.
And I think then the other thing is that if there's an expectation set from the hospital that the GP should be able to do it, and then you're feeling uncomfortable, but then your patient also has that expectation that the GP should be able to do it, and that makes it really difficult for the GP to go, no, I can't, because there's an expectation that's already been set.
But I think from a medico-legal perspective, if you feel it is outside your scope, it is not it's not something that you're comfortable or feel experienced in doing, it doesn't matter if it's within the scope of general practice in general. If it's not within your scope, you shouldn't be doing it.
I agree. Yeah.
Really,
agree.
really important to have those boundaries and not get pressurised into doing things that are outside your scope.
And one of the conversations that we did have with the HDC was that handover of care, and about the fact that if someone is transferring care to you, so if a hospital says, we're not going to be able to do this, but we expect the GP to do this, then that handover of care actually needs to be genuine and a conversation. It can't be, go back and see your GP, written in some note on a discharge summary. It should be actually a genuine handover that actually has a discussion about, I would like you to be able to do this, or to do this because we won't be doing it in the hospital. Is that acceptable? So that we do have the chance to say, well, actually, no, I don't have the services or the facility or the scope of practice for me personally that I'm comfortable to do that. So I think some of those genuine conversations need to start happening and be an expectation from within the hospital as well as from general practice that a proper handover should occur.
Communication is very, very key in this, isn't it? Both communication with the hospital, but also communication with the patient. I think that often patients may be given expectations from one service about what another service is actually able to provide, and it often causes complaints. We all see complaints coming across our desk where, the patient has been given the expectation that they can get this service for free at their GP now, and they can't. and guess what? There's a complaint. So I think actually making sure not just that we communicate across medical specialities from general practice speciality into the hospital, but also that we communicate appropriately with our patients. It means we've got to know what services are out there, because we can't create an expectation in our patients that these services are available if they're not.
So I think from everyone's perspective, don't assume that this can be done, or assume that it's going to be free, or assume anything. I think we just need to be making sure and checking in that what the service is that is available.
And I think the other thing is, if you think that the hospital or the secondary care services are asking you to do something as a GP that is beyond your scope or you haven't got capacity to do, that communication back, rather than just being about that one individual patient, it's quite useful to have that communication either through the PHO or the GP liaison or however it may be, to actually highlight that at a slightly higher level, so that hopefully that it doesn't just keep coming back again and again and again. And look, it may be that the hospital say, okay, well, we need to upskill our GPs then, and actually something happens from it in that way. But also, if you do push back with things like that and actually write, it's great to have that paper trail, because later on, if something goes wrong, it's great that you've got it on paper and it's clear to everyone what you're going to do, and who's responsible for doing what. So, Sean, what about the medical council statement on that? Have you, that you were talking about advocacy?
Well, it's entirely consistent with what you're just saying, Lucy. Yes, I mean, you have to be an advocate for your patients and try and find the appropriate services for them in terms of care, but also to follow up your point, it's really important that if those deficiencies are serious, and I wouldn't put that bar too high if I was a GP, then you should notify them in writing. And as I say, that's good both from a care for everyone perspective, because you're raising issues that are obviously patient-wide, but also for your own personal position, because it's a paper trail for you as well, if any issues arise out of that particular consultation.
And I think making sure that you have got things documented in the notes saying that have been requested to do X procedure from the hospital, and the person who's available to do this is not until next, a month's time or whatever it is. I have a situation where I do minor surgery on one half day a month in my practice. So people just have to wait for that to happen. And I can do some quite high-level procedures, but I'm the one that does them, not anyone else of my colleagues. So it is just that messaging to patients about what's available and what they can do, and making sure that they do hear, and it's documented in their notes somewhere.
Documented. So I think we're going to move on to that whole documentation now, which is one of Sean's favourite subjects. So one of the other issues when we're resource constrained and time constrained in general practice is the pressure on writing good notes. When we're busy is actually when we're most likely to miss things, or to have a poor manner with our patients, or to make mistakes. And that's when we most need good notes to show what we did. But unfortunately, the injustice of that situation is, of course, those are exactly the times when you tend to be writing the worst notes. Your notes tend to get shorter. I often go back sometimes and find I haven't actually just finished it. I thought I've had, but I just haven't written the plan and the safety net because I was rushing out the door and trying to do the next thing. So I think that's the next thing I think that's really important when we're looking at resource-constrained primary care, is looking at the notes and trying to make sure we've done them properly.
Yes, I suppose I'll come in here, Lucy, because being at the bottom of the cliff really in these situations where we're dealing with the HDC or the Medical Council, having appropriate notes is amazingly helpful, and it's multi-layered, and I'm putting a lot more pressure on people to do better notes, but it's also including negative outcomes. A lot of GPs will obviously write what they're doing, but they won't write what they might have discussed and are not doing because the time's short. But sometimes those offers of a blood test or those offers of another are incredibly important when it comes to a situation that's gone bad. The other thing is differential diagnoses. Diagnoses are really important to have those in there as well. So if you've considered all these issues, we lawyers kind of think about protecting our position all the time, and if we're giving people advice and they don't take it, it's just natural to record that. But I don't think it's understandably GPs don't think that way. They're thinking about what they're doing and what's going to be good. But negative outcomes, I think, are the most important thing. If you can think about that, and differential diagnosis, those are the things that sort of come through to me that are really helpful when you're there. And obviously, they avoid the he said, she said. At the end when it goes wrong.
But we're talking about resource constraints, and actually now you're telling us that we have to write longer notes.
I know.
And I actually think you're quite right. GPs don't often write a differential diagnosis. It's not you often put query this, query that, but it's not a very comprehensive necessarily list. And we often do write what we've decided rather than actually what we've thought about.
I think so long as the history demonstrates that you have turned your mind to brain cancer or, heart disease or whatever it is, so long as it's clear in the notes, you've thought about it, that's what's most important. Even if you don't have it spelled out in the differential, it's got to be clear.
Yeah, I agree.
And I think what you need to have in the notes is I can see what you're thinking.
Yes.
Because if I can see what you're thinking, then the next person who's reading those notes going, they were thinking that it was going to be this, and actually it's turned into that, which is completely different. But I think the other part of that safety netting, probably differential diagnosis, is I often will say to people, I think it's this, unlikely to be cancers or whatever else is. However, because I think we can be super falsely reassuring, and when things do turn to custard, it's because we've been reassuring and the patients are going, well, the doctor didn't think it was cancer. And then you've never had a follow-up plan for when it is the point at which you're going to say, oh, no, I'm not going to be reassuring anymore. So I always have dates in my mind. I say, if you're still coughing after Christmas, you're coming back to see me. Because we are often as reassuring as we can be, and that can be problematic as well.
I think to be able to say, I don't think this is cancer, I think it's this, but, just think, even if it doesn't clear up in this time, we do need to just check that out and just make sure we've, crossed our T's and dotted our I's. And so the patients have heard the word cancer, but it's like, I don't think it is. So I think a lot of it is just around how we communicate and the fact that you've put it on your notes to say unlikely cancer, and then you've ticked that box.
I often say, I don't think it's cancer, but I don't have X-ray eyes. And if your cough's not better in 3 weeks, we really need that X-ray. So again, I'm saying I don't think it is, but I think we should check. So look, do we think? I mean, we're talking about how we're going to actually manage our precious 15 minutes, and Sean wants us to write these lovely long notes. Is AI going to be our saviour here? What do we think about that?
Certainly, I think for some doctors who use it, say it's wonderful. I know that they're probably the early adopters. The rest of us are probably sitting and waiting to see what the evidence is about how good it is.
And I think it's like that keyword thing, the fact that you have keywords that go like dot abdominal examination and it has everything on it when you don't necessarily do everything. I think we just need to be really conscious of the fact that we may end up AI does summarise what we're saying, but we need to make sure it does summarise all the important parts, but also that we don't end up having a uniform, bland note that doesn't actually tell us anything about what you were thinking.
Because I think the safety net of using AI is that you're going to read them before you actually put them in the notes, that you copy and paste it and read it. But the problem is you've got that whole cognitive bias thing that actually you read what you think you're going to see, and so that sometimes it's actually hard to carefully read something. And so that's always going to be a risk. It's interesting you talk about keywords actually, because we haven't, one of the MPS pieces of advice is general is if you're going to use a keyword, you're not allowed to have the findings in there. So if you write keyword abdominal examination, you can write abdomen, organs, tenderness, but leave all those things blank so that you actually have to fill it in. And if you haven't filled it in, it's not there. You can't write soft, non-tender, no masses, no organomegaly as your keyword because you've made the findings pre-populate, and you're not allowed to pre-populate findings. And the HDC have been very, very clear that they really don't like keywords that pre-populate findings.
And I think there are ways around that because, I know with mine, I have the minor surgery that I do all the time, and it's just a pain having to write everything. But I have lesion ...
Yeah.
Whatever I've used for addressing or not for addressing, for a local anaesthetic and the the antiseptic, which is always the same. However, then I talk about what sutures I use, how long the stitches have to be in for, what I'm expecting for them to come back as a follow-up. So all those other things are all detailed and relate to that particular person. So you do have to make sure that you're filling in for that person what's actually going on. Yeah.
I think in terms of clinical notes, because we at MPS we read clinical notes all day long, obviously, and it's really interesting what you can glean and what you can't glean from someone's clinical notes. And for those who are practicing, it's like a really good thing to do is to do an audit. And the GP College have a really comprehensive audit of clinical notes. And then you can get to look at your notes critically. And I think we can be quite surprised just how good or not so good our notes can be. It's worth doing, I think.
Yeah. And I've got a variety in my practice, and we've just decided that we're going to have our clinical review session, and every quarter sit down and just select a day, pull out people's notes and go, what were you thinking? Like, what were you thinking? No. But, can I tell what you're thinking in those notes?
Are those good notes?
Yeah. So, and are they good enough for the next person who's reading them? Yeah.
Mm. Yes, and look, good notes, as Sean will tell us all, is a really important part when it comes to HDC, and actually it often leads to issues at the medical council, because the HDC will send you to the medical council if they think you've got very poor notes. And I do, however, remember a case years ago where the actual notes on the day were really poor that the doctor had written on the day of the actual incident which led to the complaint. But the HDC advisor actually had looked through the previous 5 years of notes and noted that actually the doctor had showed good critical thinking and the notes quality was good overall. And that was taken into account. So even though on the busy day that the mistake was made or the incident happened, the notes weren't great, actually the fact that that doctor had a really good history of good clinical notes actually had weight with the HDC advisor, which I thought was great. So nice to know that keeping good notes does make a difference, even if you have one bad day. Okay, so the next area of resource constraint in general practice that I thought we should have a look at is about the situation where a patient can't get an appointment for a month. I was talking to a GP recently where in the practice where he's working, you can't get an appointment for 3 months. And that creates some significant risks, both for the patient, clearly, but also for the clinicians working in that practice and the person who's triaging to decide who does get an appointment.
Yeah, we do get calls around triage processes and what's appropriate to use in a practice when just deciding who gets the on-the-day appointment. I mean, obviously MPS don't endorse any particular process, but I think it's important to have a robust system of triage, and the person who's doing the triage needs to be competent for that job because it is really important.
It is, and look, it's quite a high risk activity. It's hard enough to actually assess a patient in your 15 minutes. Actually, assessing on the phone whether they need to be seen or not is actually even harder, probably. The patient who rings up and says, "Look, I've got a cough and I'm feeling a bit short of breath," they may just have a virus or they could have a PE. And as I say, it's hard enough for the clinicians who's seeing them to make that decision. It's really unreasonable to expect a receptionist to be able to understand the potential seriousness of any given symptom, really.
And it swings and roundabouts, isn't it? The patient may bleat to the receptionist who goes, "Oh, you sound really bad and you need to come in," and they're not. Or the patient may just go, "Oh, is there an appointment?" and is really downplays everything, and they actually are terrible and go, "Oh, that's okay," and don't come in. So I think it is key to having the most skilled person who knows the questions to ask for each of those patients to say, you need to come in. No, you don't. Yeah.
Look, I absolutely agree. I think that practices just have to have a system in place where, for any clinician, and I mean nurse practitioner or doctor, or anyone involved in the triaging decisions, the Medical Council statement is quite clear on this. It says, as far as possible, assessment should be fairly established the patient's priority for treatment compared to that of other patients, and also, more importantly, prioritisation systems should be fair systematic, consistent, evidence-based, equitable, sustainable and transparent. So the important part of that is you need to have a transparent, objectively sound system in place if you're challenged. So that is, I think, a very, very important aspect of this.
It's really hard, though. It's
gotta-
really, really hard. And making sure that the most serious patient is seen is probably one of the most challenging things that we do. I think there are lots of systems that are available that clinicians can use to help with prioritisation tools, but none of them are fail-safe. But I think that if you can show that you've tried your best to do that and that you haven't discriminated, that I think that in general, the fact that you've used some system to try and do it is probably helpful. What do you think, Sam?
No, I agree. You do need to have some system, and I really agree with Sam's comment around having the most skilled person doing triage, because on the phone it's very easy to miss things, very easy, and so you need to have the antenna up all the time. So to have a system and to have the right person, I think, is what you need.
And I think a lot of people have tried it and then go, oh no, this is too hard and I don't want to. But actually it's one of those things, if you persevere, it actually works really well. So we have a system where all the triage happens at 10 o'clock in the morning. It's put on one doctor's list. There are slots that are available in the afternoon or immediately, it's like within an hour or two. And then if those aren't used because there's not enough triages in the day, then those slots all get opened up and so that anyone else can come in, and we hold a waiting list process so that people who wanted an earlier appointment then can come and use those urgent appointments. So I think there are systems that you can put in place that work really well, but there's a level of perseverance that has to happen to bed those things in so that they work well for your practice. Yeah.
Yeah, no, absolutely. I mean, that sounds like a great system. And when it works well, it works well. And I think that the other thing that's really important is communicating with your whole patient population. So that if people ring up and they're told by the receptionist, so we've got no routine appointments for 2 weeks, and so the patient books the 2-week appointment, that patient may not have known that there was a triage service. So I think people should be told, we have a triage service for urgent appointments. If you think you're urgent, this is how you access that. We're booking our normal appointments at the moment at 3 weeks. If you have concerns about that, you could email in the practice and ask us to review. We want to make sure the patients have got all the information that they could possibly have to be able to alert the system if actually the appointment they've been given isn't timely.
Yeah. And I think that's training of your reception staff is really important, because often we don't think about their training. And their training, there's 2 ways of doing it. One of them is sort of like still being welcoming but saying no. So the computer says no, it doesn't actually say no. I think the other thing is making sure that you have some systems so that people can connect in a variety of different ways. So we have our prescriptions. They can email, they can phone in, or they can do it on Manage My Health. So there's 3 different ways that they can do it. Our nursing staff look after a whole lot of it, and the doctors look after the Manage My Health stuff. But then we take that offline to a doctor who's not actually working that day. So it's not another burden to do. It's a separated out burden that someone does discreetly, because it's quick and it's easy and you can just run through it. But it puts your head in a different space, and you don't want to be doing the complex patient order, sorting out their day and then have to go and put your head in a different space. So I think if you can think about the way we think over a day, then that would be really helpful.
What we're really talking about is efficiency. That if we can make general practice as efficient as we possibly can, it saves time.
Yeah.
People work at top of their scope, and it means that you can see more patients, hopefully more efficiently, and everybody will win that way.
I just wanted to quickly mention here about the fact that NPS membership these days actually only covers the actual clinician who holds it, if you've got an individual membership. So it's really important, if you do want the other members of your practice team covered for issues such as complaints about making appointments, then you should contact our membership department and talk to them about the practice package, because that actually means that your receptionists, your nurses, your practice manager, other people have also got that cover. And that's really important when we're looking at systems where we're using other members of our practice team who actually may be criticised about a decision that they've made. but one very last thing to talk about, because we're running out of time here, but I just wanted to talk about what happens when resource constraints gets to the point that the GP is retiring and there's no one to take over their practice. This is a call that I got reasonably recently, where a doctor was retiring and hadn't got anyone to take over and was asking about what their obligations are. So, Sam, I don't know, have you got any thoughts on that, about how you actually retire?
Well, they're not allowed to retire.
Oh, right.
Until somebody replaces them.
Oh, right.
No, I mean, it is extremely difficult. No, and because, doctors on the whole are really dedicated and they don't want to leave their patients without anyone to cover them. But the reality is, if you need to retire, you need to retire, and that's your choice to make. But there are ways you can do that. If no one's going to buy your practice or take over, then I think it's important that you look at the options around your local area as to which other practices perhaps are taking patients, and then to give your patient population a big heads up to say, I'm going to be retiring in 3 or 6 months' time, and now's the time to start looking around for another general practice to enrol to. And so I think if you communicate that well, you could probably transition over time, rather than it being a sudden, I'm leaving next week, and then you find all your patients having a great deal of difficulty.
I was talking to someone in Australia, and he was in a practice and there was 2 practices in the town that they were in, and they had sort of enough doctors to cover the population that they were serving. And I said, what are you doing about your succession plan? And he goes, I've been trying for years to try and get someone and I haven't actually found anyone. And I said, well, have you thought about amalgamating? And he goes, oh no, they do a different process to me, and we wouldn't suit each other. And I was going, so what are you going to do? And he says, I'll just shut the door. And I went well, isn't that amalgamating by some other reason?
Yeah.
So I think we do have to sort of think a little bit more broadly about the fact that there are other options, that if we did just shut the door, what would that mean? And then work out a process that's actually much more enabling and caring for our patients, and that will enable them to sort of have a smooth transition of their care rather than feeling abandoned. And I think even if you don't agree with the practice down the road, your duty of care probably to your patients and saying, look, they may be a slightly different philosophy from me, but they will continue to provide you with care, and think about it that way. I think there are other options and people you can discuss stuff with, and it doesn't need to be one person who buys your practice. It might be others. And I remember many years ago, one of the practices seniors was selling, and GPs, we work way beyond our retirement age in general, because it's such a gratifying job. Although we moan about it sometimes, it's actually a really lovely job that we do and very rewarding. But he sold his practice to his practice manager and one of the nurses, and that was 20 or 30 years ago, which is one of those whoa, what are you doing? And whereas that's quite normal now to have someone else who owns it, and you are the clinical person, not necessarily the owner. Yeah.
And I do think making those arrangements makes your life much easier, because I think the issue then becomes, if you just shut your doors, what about the notes? What do you reckon, Sean?
Well, you've got to keep them for 10 years.
Yeah,
so
it
is an obligation on you, unless you can get consent to transfer them. And that is a long time, but that's unfortunately what you're going to have to do. So taking time, as Sam says, to work out a plan is really beneficial.
So if you transfer them, obviously with the patient's consent, then you're allowed to let somebody else, that person then takes over that responsibility. Correct. For holding those notes for 10 years. So you are saving yourself a lot in storage lockers for.
Yeah, and I think something to think about. If you're heading for retirement and all your notes are on paper still, you have to have a system that you set up for how you manage those, because no one from another practice wants to receive 3 cupboards full of notes from your patients. So we strategically talked to MPS and Medical Council and worked out what it was that we needed to do for our patients. It took us almost a year, but we scanned in everything back to 10 years that was in all our paper notes, and then we wrote to every patient. We sent out a Manage My Health message to everyone and said, we have your patient records, we've got everything scanned back to 10 years. We'd been on computers for 20, so that it was only the 10-year bits of paper that we were scanning back. And what do you want us to do with them? We will shred them for you, or you can take them away. And so that was the 2 options. And so over that year, we shrunk our 4 massive cupboards down to nothing. So now we have only bits of paper that have got a signature on them that we require, and everything else is actually electronic. So that means that if we did close the door tomorrow, we could electronically send the notes to wherever someone wants to go.
I often wonder, though, what's going to happen if you shut your doors and you've got an electronic system and you stop paying your PMS subscription every month, then you have no access to those notes anymore, which means you can't transfer them to anyone else after that point. And is that kind of it's one of those thoughts I've had that I haven't got the answer to. But anyway, on that unanswered question, we might just leave that from here. Look, I hope that this podcast has been helpful. I know, as Sam Murton has said, general practice is a hugely rewarding job, and that the resource constraints, although very real and obviously affecting us all every day, there are ways of keeping ourselves safe. And so I think the things to take away from today's podcast is probably about making sure you've got some really good systems. If you're delegating things, that you've got well-trained people and good protocols around that. And that when you're making decisions about care, making sure that you're advocating for your patients, they're at the centre of all your decisions, and that if you do have concerns about resource constraints jeopardising the care of the patients, that you write to someone, whether that's Te Whatu Ora or your local hospital or your PHO, and have a really good email trail or paper trail that you have tried to do something about that. So our next podcast is going to be covering aspects of secondary care resource constraints. So I hope you'll tune in for that. Otherwise, we look forward to catching up with you on our next podcast. If you like the Medical Protection podcast, please subscribe and leave a review. If you'd like a podcast on a specific topic or that you've got any feedback for us, please email us on nzpodcasts@medicalprotection.org. Thanks, guys.
Thank you.
Lucy.
Thank you.